Good afternoon, good morning, everyone. We'll get started here in just a few seconds. Thanks so much for joining. Okay, we're ready to get started here. Thank you so much, everyone, for joining today's webinar. I truly appreciate your participation and look forward to a great event. My name is John Eller. I'm with Plexus Communications, the medical education company just helping to put together today's program. We're really grateful for the opportunity to work with the Leukemia Research Foundation and really thank them for their partnership in this program. And now I'll get to turn things over to Lindsay White, who's the Director of Programs and Partnerships at the Leukemia Research Foundation. And she's going to be moderating and taking over the webinar from here. So Lindsay, I'll go ahead and turn things over to you. Thanks so much.
Thank you, John, and thank you, Plexus, for including Leukemia Research Foundation in this important topic, this webinar today for AML patients with the FLT3 mutation. We're joined today by Dr. Eitan Stein from Memorial Sloan Kettering Cancer Center in New York, who's going to talk a little bit about various options for patients with the FLT3 mutation, talk about how patients can interact with engage with their care providers, their doctors, and care team to make sure that they're aware of their options and that the treatments that they receive are the best suited for their particular situation. And he will respond to some questions that have been submitted previously or will be submitted today during the course of the session. The Leukemia Research Foundation's mission is to cure leukemia by funding innovative research and supporting patients and families at the same time. The foundation has raised over $90 million in support of our mission since our founding in 1946. And we funded research grants to over 750 researchers worldwide during that time. Our support programs for leukemia patients and their loved ones include information and resources, education programs, financial assistance, and a directory of other helpful organizations on our website. Just a few quick housekeeping items. For the program today, all participants will be muted throughout the program. If you already submitted questions, a question at registration, we have your questions and we will do our best to get to all of the questions. So you can also type a question in the Q&A box at the bottom of the screen. And we'll do our best to get to everyone's question. If some are kind of replicated, we'll group them together and try and cover everything. After today's program, you'll be sent a brief evaluation through email. So please take a moment to complete the evaluation so that we can make sure that we improve our programs. And also this program is going to be recorded and it will be available on our website and probably on Plexus's as well. I'm not sure. So we're grateful today to have Dr. Eitan Stein from Memorial Sloan Kettering Cancer Center in New York. And he is a hematology oncology physician who specializes in caring for people with acute and chronic leukemias, also myelodysplastic syndromes and myeloproliferative neoplasms. He's dedicated to providing his patients with the best care tailored to their unique situation. To do this, Dr. Stein works together with his patients to develop a personalized treatment plan that takes into account their needs as well as their families. Dr. Stein is also an active clinical researcher who develops new and innovative approaches to treating acute myeloid leukemia. As a principal investigator on a wide variety of clinical trials for people with AML, Dr. Stein works to develop new therapies that can more precisely and effectively target AML. His goal as a doctor and researcher is to help people with AML and other blood cancers have the best possible outcomes. I'm very grateful that he's joining us today. Dr. Stein, please take it away.
Okay, thanks so much, Lindsay, and thanks, John. I'm gonna let me share my screen. And what I'd like to do over the next 30 to 45 minutes, is just give everybody a brief overview on some advances in the treatment of acute myeloid leukemia that harbors a specific mutation in a gene called FLT3. These are my disclosures. All of these companies make FLT3 inhibitors. And this activity was supported by an educational grant from Daiichi Sankyo. Okay, so what we're going to talk about today briefly is the role of FLT3 mutations and maybe biomarker testing more generally in acute myeloid leukemia and how we use that testing to come up with treatments for specific newly diagnosed patients with AML. We'll talk about differences in the mechanism of action and personalized treatment considerations for selecting among the various FLT3 inhibitors that are currently available for use. We'll look at some clinical trial data that talks about new and emerging FLT3 inhibitors and how we might combine FLT3 inhibitors with other standard of care agents to improve the outcomes of patients with acute myeloid leukemia. And finally, I'm skipping to item 5. We'll also define TRAEs, which stands for treatment-related adverse events. That's a doctor's way of saying side effect profiles that are associated with the FLT3 inhibitors. And then how do we manage those side effects so that the patients don't suffer from significant side effects while they are taking these drugs? Okay, so just to zoom out for a second and think about acute myeloid leukemia more broadly, something that many of you may already know is that acute myeloid leukemia is a rare cancer, but it's quite serious. There are only about 20,000 new cases of AML per year in the United States of America. But if you think about that, comparing it to other kinds of cancers, there are 200,000 cases of breast cancer every year in the United States. So that makes acute myeloid leukemia actually a relatively rare malignancy when you think of it in the context of other more common types of cancer. But despite the fact that it is a more rare malignancy, one thing to remember is that it's primarily, not always, but it's primarily a disease of aging, with the median age of diagnosis being 69 years old, and patients most frequently diagnosed between the ages of 65 and 74 years old. You all know that the American population is aging, right? All of the baby boomers now, like my parents, are in their late 70s, early to mid 80s. And because we're seeing this increase in the amount of people who are in that age range, the absolute number of patients with acute myeloid leukemia is going up year over year. So when I started my practice back in 2013, the number we used to quote people was about 15 to 16,000 cases of AML per year in the United States. And now, as I just said, there are over 20,000 new cases per year in the United States of America. For reasons that are a little bit unclear, AML is slightly more common in men than in women, with men having 5.1 new cases per 100,000 people and women having 3.5 new cases per 100,000 people. So this is a little bit of detailed data about the FLT3 gene. Okay, so this is a little bit of high-level data, but I know that all of you guys can handle it, so we're going to go through it a little bit quickly. But FLT3, the FLT3 gene makes the FLT3 protein. And the FLT3 protein is a normal protein that is expressed, meaning it is found on a wide variety of cells in the human body. One of the types of cells that it is found on is blood cells. So all of our blood cells, including blasts, which are the leukemia cells, have a FLT3 protein that is part of the normal function of that blood cell. The thing that goes wrong in patients with acute myeloid leukemia is that FLT3 protein that should be normal becomes abnormal and develops a mutation. So what does that specifically mean? What that specifically means is that when this protein develops a mutation, it's like a switch is flipped, and that protein causes the leukemia cells just to proliferate and grow and grow and grow. So the analogy I like to use is, normally when you go, like when I came into my office this morning, in order for the lights to go on in my office, I had to, press the button on the wall, and that's what made the lights go on. But imagine if you had a system where the button pressed itself and the button would never go off. The lights were always on and there was no way to shut them off. That is what happens in patients who have FLT3 mutant acute myeloid leukemia. That protein is always on, causes the proliferation and the propagation of acute myeloid leukemia, and never gets shut off. That is the reason that many patients with newly diagnosed acute myeloid leukemia who have a FLT3 mutation will have a very, very high white blood cell count when they are first diagnosed. So a patient with AML with a FLT3 mutation, the most common way that I find out about them is that they'll go to their regular primary medical doctor who will do a routine complete blood count. And that routine complete blood count will show a white blood count that is quite elevated, 50,000, 60,000, 70,000, when a normal white blood count is really less than 10 or 11,000. And the reason that's happening is because this switch, this FLT3 switch that is turned on and giving a signal to these cells to divide and divide and divide, and all cancers are the consequence of unbridled and uncontrolled cell growth. So there are two different types of FLT3 mutations. There's something called an internal tandem duplication, known as an ITD, and then there's something called a tyrosine kinase domain mutation, known as a TKD. FLT3 mutations, both the ITD and the TKD, occur in about 30% of patients with acute myeloid leukemia. So they're actually quite common. They occur in a third of the patients that I see with newly diagnosed AML. And both of these mutations, as I just mentioned a second ago, lead to the active switching on of this gene that typically should usually be switched off. All of this gobbledygook that I'm showing you on this slide here is really meant to illustrate one point. So what I want you to do is don't look at the column that says genetic abnormality. Just look at the left-hand side at the column that says risk category. So when I have a newly diagnosed patient with acute myeloid leukemia, one of the first pieces of information I'm trying to get from the bone marrow biopsy of that patient is whether the patient falls into the favorable risk category, the intermediate risk category, or the adverse risk category. And those categories are defined by the chromosome abnormalities and the mutations that are found in that bone marrow biopsy at the time of the initial diagnosis. So let me tell you why this is so important. It's important because we treat patients with favorable, intermediate, and adverse risk disease somewhat differently. Those patients with favorable risk acute myeloid leukemia, especially when they're getting intensive induction chemotherapy with strong chemotherapeutic agents in the hospital, our general feeling is that for those patients, they don't need to have a bone marrow transplant or a stem cell transplant after they go into remission. Those patients can be cured without a stem cell transplant. For the group of patients who are adverse risk, those patients we typically think after they get into remission, in order to be cured, they do need a stem cell transplant. And the stem cell transplant is the thing that sort of seals the deal that hopefully the leukemia will not come back. But then you have this large group of patients with intermediate risk acute myeloid leukemia. And these are patients that are not favorable risk or not adverse risk. And I think the question becomes, in those patients, especially for certain subtypes of intermediate risk AML, do those patients need to have a stem cell transplant to be cured, or could they potentially be cured with chemotherapy alone? So what does this have to do with FLT3 mutations? Well, as of 2022, we put patients with FLT3 mutations into the intermediate risk bucket. And it used to be, up until about 6 months ago, that I would tell everyone who had a FLT3 mutation, who got into remission, that if they were a candidate for a stem cell transplant, that they should have a stem cell transplant. But over the past 6 months or so, there has been some data that has emerged suggesting that perhaps there are certain patients with FLT3 mutations that don't need a stem cell transplant in order to be cured. So let's talk about the treatment options for patients with newly diagnosed acute myeloid leukemia with a FLT3 mutation. Sorry, hold on one second. There's just a fire alarm in the building, but it sounds like it's not on my floor, so I'm going to keep going. Okay, so we talk about patients who are eligible for intensive chemotherapy, and then we talk about another group of patients who are ineligible for intensive chemotherapy. So, and we'll talk about who's eligible and who's not eligible in a second. But patients eligible for intensive chemotherapy, typically with a FLT3 mutation, typically will get intensive, what's called induction chemotherapy, with a regimen like 7+3, which is a strong chemotherapeutic regimen that lands you in the hospital for about a month. And it gives people a drug called cytarabine in combination with a drug called daunorubicin. And we combine that with a FLT3 inhibitor, either midostaurin or a drug called quizartinib, for those newly diagnosed patients. And I'll show you the data about why we do that. There are other patients who unfortunately might be too old to get intensive induction chemotherapy. And that's because the side effects of intensive induction chemotherapy are just a little bit too tough for those patients. And for those patients, the standard of care is typically to give them a treatment which you can do outpatient, which doesn't have as many side effects. The most common treatment is the combination of two drugs, one called azacitidine and the other called venetoclax. There are some centers that will add on a FLT3 inhibitor called gilteritinib to the azacitidine and venetoclax, although I don't think that yet that would be considered the standard of care. So who are patients who are probably not eligible for intensive induction chemotherapy? So in my practice, a patient who's older the age of 71, 72, 73, it's rare that I would give that patient intensive induction chemotherapy. Certainly if the patient is over 75, I would shy away from any sort of intensive approach and give that patient a lower intensity treatment. Comorbidities, so that means if the patient has some other medical problem that's going to make them have more side effects with intensive induction chemotherapy, I would shy away from giving it. So what are those comorbidities or those other medical problems? So you can think about sort of common things that happen in older people. So patients who have heart problems or significant heart problems, kidney problems, if they have lung problems, they're on supplemental oxygen or their livers don't work well, those would be patients that we would prioritize for lower intensity treatment. It's very hard to give a patient who is older and has some cognitive dysfunction or dementia intensive induction chemotherapy because they're often not able to sort of cooperate with what is needed in order to get patients through intensive induction chemotherapy. And the overall survival of all of these patients, this is patients, generally, if you think about giving intensive induction chemotherapy to someone who's 80 years old, because we used to do this, I mean, before I practiced, but in the 80s and 90s where we didn't have a lot of treatment, people tried to give intensive induction chemotherapy to sort of 80-year-olds because that's all we had. And what they found is that the mortality, meaning the number of people who died within the first couple of months of treatment, could be as high as 30%. So that obviously is not something that you want to do if you can avoid it. Okay. So the first clinical trial I'm going to talk about that establishes giving a FLT3 inhibitor in combination with intensive induction chemotherapy for patients with newly diagnosed AML with a FLT3 mutation is the one I'm showing you here called the RATIFY trial. So I'm going to take you through this because I know that many of you may not have seen a diagram like this before. So on the far left-hand side in the box, what that describes is the population of patients who were included in this clinical trial. These patients were patients with ND AML. ND stands for newly diagnosed acute myeloid leukemia. That is, these patients had never had any other treatment for their acute myeloid leukemia, and they had a mutation in either the FLT3 ITD or the FLT3 TKD, which we talked about before. And these patients were either 16 years old and up to 60 years old. Okay, so this is a population of patients newly diagnosed AML with a FLT3 mutation up to the age of 60 years old. And then of all the patients who were screened for this trial, 717 were enrolled. I'm moving a little bit farther to the right where it says N equals 717. And then a computer flipped a coin and randomized those patients, meaning the computer decided in a one-to-one fashion, meaning half the patients ended up getting the treatment at the top of the line, and then half the patients ended up getting a treatment at the bottom of the line. Actually, let me see if I can just add in a pointer here. Yeah, so you should be able to see that half of the patients got the treatment on this line over here, and then the other half of the patients got the treatment down here. So what was the difference between the treatments? So the treatment at the top of the line, half the patients got standard 7 and 3, which is daunorubicin and cytarabine, with a placebo pill, so basically a sugar pill. And half of the patients got daunorubicin and cytarabine with a weak FLT3 inhibitor called midostaurin. So those patients either got 7 and 3 with placebo or 7 and 3 with midostaurin. Those patients who achieved a complete remission went on to get more chemotherapy called consolidation, either with a placebo or with midostaurin. And then patients either were given placebo or midostaurin as a maintenance therapy. This was a very, very large clinical trial that took over 10 years to enroll. So what are the outcomes of this clinical trial? So what I'm showing you on the bottom left here is what's called a survival curve. Again, many of you will have seen this, but I'm just going to walk you through it so you understand for those of you who haven't seen it. So a survival curve works like this. If you look on the y-axis over here, this is the percentage of patients who are alive. And the x-axis over here is time. So you can see that at time 0, because patients, have just entered into the trial, they haven't gotten any treatment yet, 100% of the patients are alive, right? So time 0 is essentially day 1 of the trial, where everybody is alive. And then as time goes on, month 1, month 2, month 3, month 4, et cetera, what you can see is that that survival decreases. And it decreases based on what line that you're on. So this is actually years, not months. So at 4 years, 51% of the patients who had received midostaurin were alive, compared to 44% of the patients who had received the placebo, right? So that's a 7 percentage point increase in overall survival at 4 years, meaning that patients who received midostaurin as a group had a better survival or lived, or more of those patients were alive than the patients who had received placebo. And because of this, the standard of care became that the midostaurin with chemotherapy was the standard of care. This trial, there was some data recently published at this year's big international hematology meeting that looked at how these patients did if you followed them out longer than 4 years and followed them out to 10 years. So 120 months ends up being 10 years. And you can see that just like when you followed them out to 4 years, those patients who had received midostaurin in the orange had a longer survival than those patients who had received placebo in the blue. So this established that midostaurin in combination with intensive chemotherapy in newly diagnosed AML was the standard of care. Okay, so now we're going to move on to another trial. And this trial is with a different FLT3 inhibitor called quizartinib, which is listed up here. So what is the difference between quizartinib and midostaurin? The difference is that quizartinib is a more potent and more targeted FLT3 inhibitor than midostaurin. Okay, so if you knew nothing else about quizartinib and midostaurin beyond what I just told you, I think what you would think, or what I thought when this trial was being designed, is that a better FLT3 inhibitor should lead to better survival in patients with newly diagnosed FLT3 mutant acute myeloid leukemia than a weaker FLT3 inhibitor like midostaurin. So that was sort of like the hypothesis. So this trial, again, looking at the far left over here, was for newly diagnosed patients with FLT3 mutant acute myeloid leukemia. It was different than the prior trial in that in this trial, patients could be up to the age of 75 years old. The previous trial was only up to the age of 60 years old. And just like the prior trial, patients were randomized in a one-to-one fashion, meaning half the patients were given either cytarabine, daunorubicin, and a sugar pill and a placebo, or half the patients were given cytarabine, daunorubicin, and this very potent FLT3 inhibitor called quizartinib. Now, for those of you who are still paying attention, you might ask the question, wait a second, Eitan Stein, you just told us that the standard of care for FLT3 mutant acute myeloid leukemia is 7 and 3 with midostaurin. So in this trial, why are half the patients not getting 7 and 3 and midostaurin, and they are getting a placebo, right? If the standard of care is to get 7 and 3 and midostaurin, why are half of the patients being deprived of the standard of care? So the answer to this question is as follows. It's sort of an unsatisfactory answer, but I'll give you the answer anyway. This trial started before midostaurin was approved. So midostaurin was not available for those patients you might have wanted to give it to. That was one issue. And then once midostaurin was approved, the trial actually sort of finished up. It was approved in the United States, but the trial was open in many, many countries where midostaurin was not approved and no one had access to midostaurin. So the trial finished up in those countries. Okay, somewhat unsatisfactory, but that's sort of the reason the trial went on this way. So what were the results of the trial? So here are the survival curves again. Again, at time 0 down here, 100% of the patients are alive. The orange line is quizartinib. The blue line is the patients who got placebo. And you can see at 31.5 months, about 50% of the patients who get quizartinib are alive, and about maybe 42% or maybe 41% of the patients who get placebo are alive. So what are the takeaways from this study? So the takeaways are as follows. Number one, giving quizartinib is better than giving a placebo, right? Because the patients who got quizartinib lived longer than the patients who got the placebo. Okay, but I think what is interesting about this trial is that the magnitude of the difference between the orange line and the blue line is actually not nearly as big as I thought it would be. So what I would have expected when I went into this study is I would have expected, wait a second, if quizartinib is a much stronger drug than midostaurin, then the difference in the survival should be like this. You should be able to drive a truck through that survival curve. But it really isn't. It looks very, very similar, and I don't think we understand why that's the case. And I think that is why it has become that the standard of care for patients with newly diagnosed AML with a FLT3 mutation is to definitely get 7 and 3, but we don't know whether a patient should get quizartinib or midostaurin. So different centers do different things. I would say that some institutions give quizartinib with 7 and 3, and some patients give placebo with 7 and 3. The other thing that's interesting is that if you look at the group of patients on the right-hand side who were older than 60 years old, so those are the patients between 60 and 75 years old, what you can see is that the survival between the quizartinib in orange and the placebo in blue, those lines now overlap, meaning there doesn't seem to be any benefit to giving quizartinib or a FLT3 inhibitor, this FLT3 inhibitor, to patients older than the age of 60. The benefit only really seems to be with giving the quizartinib in patients younger than the age of 60, where there's a difference on the left-hand side in these two survival curves. Okay, we are actually going to skip this trial for a second, and we're going to skip this trial, and we're going to, just because I want to have time for questions, and we're going to move on to this trial over here. Okay, so what I just talked about a second ago is I talked about the patients with newly diagnosed acute myeloid leukemia who are fit enough and young enough and strong enough to get intensive induction chemotherapy. And I think I convinced you, hopefully, that if you got a FLT3 mutation and you have newly diagnosed AML, you definitely want to add on a FLT3 inhibitor to your intensive induction chemotherapy. But what about for that large group of patients who are older and can't get intensive induction chemotherapy? So in those patients, the standard treatment regimen is the combination of two medications, the first two on this list here, one of them known as azacitidine and one of them known as venetoclax. And there is a clinical trial that has really been pioneered at the MD Anderson Cancer Center, adding on a third or a different FLT3 inhibitor than the ones I've told you about before, called gilteritinib, to azacitidine and venetoclax. And what happens is that the azacitidine and venetoclax are given together, and then the gilteritinib is given continuously for 28 days. These are the results of that clinical trial. It's only 30 patients, so it's a very small number of patients. And whether this actually is true, if you did a bigger study, I think is unclear, but at least the preliminary results are quite impressive. So this thing over here that says MCRC, that means the complete remission rate. And you can see that 100% of the patients on this trial achieved a complete remission. And if you look at the survival curves, this is on the left-hand side and on the right-hand side, let's look at the right-hand survival curve, which is overall survival. You can see at 6 months that just about 25% of those about 93, at 6 months, 93% of the patients are alive. At 18 months, 72% of the patients are alive. If you look at the same data by just giving azacitidine and venetoclax, that data doesn't appear to be as good. There's now a randomized trial where patients are being randomized either to receive azacitidine and venetoclax or to receive azacitidine, venetoclax, and gilteritinib. Okay, the last trial I want to talk about is a maintenance trial after a stem cell transplant. I don't want you to look at that yet, so I'm just going to talk. So we talked about giving a FLT3 inhibitor in combination with chemotherapy for newly diagnosed acute myeloid leukemia, whether you're receiving intensive induction chemotherapy or whether you're not receiving intensive induction chemotherapy. I told you at the very beginning of the talk that for many patients who have FLT3 mutations, what will happen is they will get intensive induction chemotherapy, they'll get into a remission, and then what will happen is that those patients will go on to an allogeneic stem cell transplant, okay? And after their stem cell transplant, the question always becomes, what can you do to help prevent the patient from relapsing? Because despite the fact that allogeneic stem cell transplant is an outstanding treatment, unfortunately, there are some patients who still relapse after a transplant. And the question specifically for this talk is, if you had a FLT3 mutation when you were diagnosed, is there any benefit to adding on a FLT3 inhibitor after an allogeneic stem cell transplant as a maintenance therapy, where patients are just taking a pill, sort of for a year or two to help prevent their leukemia from relapsing? So similar to what I told you before, if you had asked me before, or when people asked me before this trial was started, whether there was going to be a benefit to giving patients a FLT3 inhibitor as an oral maintenance therapy after a stem cell transplant, I would have told you there will definitely be a benefit to it. In fact, some people thought doing a randomized trial where patients after a transplant were randomized to receive either gilteritinib, the FLT3 inhibitor, or a sugar pill, a placebo, was unethical, because everyone knew in their heads that this trial had to be beneficial, or receiving a FLT3 inhibitor must be beneficial to the patients. So there was, though, a randomized clinical trial done where patients who had a FLT3 mutation at the time of diagnosis were randomized to receive either the FLT3 inhibitor gilteritinib or to receive a placebo, a sugar pill. And if you look at the survival curves on the right-hand side, what you see is that there is actually no benefit to giving maintenance therapy with a FLT3 inhibitor after a stem cell transplant. It doesn't seem to help patients live any longer, okay? And you can see that these curves are basically overlapping, and statistically, these curves are equivalent. So why would that be? Why would it be that patients who are getting a maintenance therapy actually aren't getting any benefit from that maintenance therapy? Well, one possibility is that patients who got the placebo, when they actually did relapse, those patients were then unblinded, meaning they were told that they were getting a placebo, and it gave the doctor the opportunity at that point to give the patient the FLT3 inhibitor. And by having the opportunity at that point to get the FLT3 inhibitor, that put the patients back into remission and kept them alive as long as the patients who got the gilteritinib. But there was one group of patients who did benefit from getting the gilteritinib maintenance therapy. And that group of patients was the group of patients who, when they went into having their stem cell transplant, they had microscopic evidence of FLT3 still in their bone marrow by an extremely sensitive test. So all of these patients, they got intensive chemotherapy, they got into remission, they were all in remission, but right before the bone marrow transplant, this extremely sensitive test was sent to a lab, and those patients who were found to have a little bit of FLT3 left over in their bone marrow, even though their doctor might not have been able to see it by standard methods, those patients seemed to really benefit from getting the FLT3 inhibitor, while the gilteritinib. While those patients who did not have any FLT3 mutation present, those patients didn't benefit from getting the FLT3 inhibitor, probably because the patients were already cured by having the allogeneic stem cell transplant. Okay, so with that, I am now going to conclude, and that gives us a few minutes for questions, which is always my favorite part of these kinds of talks. So we talked about how midostaurin in combination with chemotherapy is the standard of care for newly diagnosed patients with FLT3 mutant acute myeloid leukemia, as is quizartinib, a more potent FLT3 inhibitor in combination with intensive chemotherapy. That combination of quizartinib with chemotherapy leads to an overall survival benefit, but that survival benefit is primarily in patients less than the age of 60 years old. We talked about how giving patients maintenance therapy with a FLT3 inhibitor after a transplant seems to benefit those patients who have MRD at the time, or measurable residual disease at the time they go into their transplant. We talked about how giving lower intensity therapy with azacitidine, venetoclax, and gilteritinib might be better than giving just azacitidine and venetoclax for older patients with FLT3 mutations. And we actually are going to have a trial now, which I didn't mention, that is looking to see whether the FLT3 inhibitor gilteritinib in combination with chemotherapy is better than the FLT3 inhibitor midostaurin in combination with chemotherapy. And with that, I thank you very much for your time. I'm going to get rid of the slides, and I'm happy to take the pre-specified questions and any additional questions that you may have.
Great. Well, thank you so much for that. That was very clearly presented and super helpful for me, I know. So I'm just going to start reading through some of the questions that we received ahead of time. The first one is, What would be the plan of treatment for a patient with AML and FLT3 in case of relapse after bone marrow transplant more than 6 years ago?
Oh, that's a hard question. Right. So let me just present the case again to the group. So it sounds like this is a case of a patient who had acute myeloid leukemia, got into remission, got a stem cell transplant, and then 6 years later ends up relapsing with a FLT3 mutation. Um, So let me say why I'm talking about this case being, or this clinical scenario being difficult. So it's difficult because most patients with acute myeloid leukemia relapse within the first couple of years. So it's pretty unusual for a patient to relapse after 3 years. I mean, I've treated patients like that, but I can probably, probably 10 to 20 at the most in my career. So whenever a patient relapses that far after a stem cell transplant, one thing that's really important to do is to make sure that it's basically that the genetics of the relapse leukemia are the same as the original leukemia. So sometimes the genetics can shift over time, which makes it sort of it's still leukemia, but it can be a slightly different disease. Um, if the genetics of the leukemia are really exactly the same, I think you would have two different options, and it would probably depend on the age and the health of the patient. I think one option would be to give just a targeted FLT3 inhibitor called gilteritinib for relapse disease. That's based on a trial we didn't talk about that shows that gilteritinib is better than chemotherapy when patients have relapsed AML with a FLT3 mutation. But the problem is, I don't know how many of those patients on that trial relapsed after 6 years. Meaning, I think that trial was primarily patients who relapsed pretty quickly. So I would give significant consideration to giving, another round of intensive chemotherapy in a patient who relapsed 6 years after their initial um, diagnosis. Again, it'd be easier for me to give intensive chemotherapy to someone who is 30 years old compared to someone who is 75, where I would probably just stick with the FLT3 inhibitor.
And when you say the chemotherapy, would it be the chemotherapy plus the FLT3 inhibitor?
Right. That's a really good question also. So we have no data about what to do. So um, having said that, I'd probably give chemotherapy with a FLT3 inhibitor. Yeah. I'd probably treat it like sort of like even though it might not be a new AML, I'd probably treat it like I'd probably start over, understanding that we try to be data driven and it's really like a data free zone, whether how much the FLT3 inhibitor benefits the patient in that situation. But extrapolating from the other data, I'd probably give a FLT3 inhibitor with it. Yeah.
Okay, great. I think generally speaking, it sounds like it's very important for patients and their families to make sure that the testing is repeated.
Yeah, as a general rule, things in acute myeloid leukemia, the genetics of the disease can shift over time. And whenever someone relapses, it's really important to do that initial molecular genetic testing all over again. Because actually something that's really interesting is that 30% of patients who do not have a FLT3 mutation when they are diagnosed will develop a FLT3 mutation when they relapse. So if you don't test for it, you're not going to know that it's there. And giving a FLT3 inhibitor really seems to benefit people. So like at Memorial Sloan, I can speak about my own experience. At Memorial Sloan Kettering, we do genetic testing with every bone marrow biopsy because we think it's important to know how the disease genetics are shifting over time because it can open up new treatment options and new options for clinical trials to help improve the outcomes of patients.
Great. And that actually, I think, kind of leads nicely into this next question. And the next question takes into consideration patients who maybe had this mutation 10 years ago, but didn't have the benefit of the treatments that we have today? How has the prognosis for these patients or, changed over that time?
I mean, the prognosis is much better for FLT3 mutant patients. So, I showed, I think it was slide 3 or slide 2, that categorization of favorable, intermediate, and adverse risk disease. So patients with FLT3 mutations used to be solidly in the adverse risk group because those patients would relapse really quickly and it was very, very hard to cure them. But with the new treatments, actually, our patients with FLT3 mutations have now sort of improved their lot and moved from the adverse risk group. Now they're by definition in the intermediate risk group. And that's like really kind of amazing. And we have much better, I mean, there are a variety of reasons why that has happened. Number one, it's because we have, better FLT3 inhibitors like we talked about. The other thing is that more patients are getting stem cell transplants. So, 10 years ago, I think we would hesitate to transplant a patient who is 70 years old. And now, at least at Memorial Sloan Kettering and many other large institutions, we often say that there is no upper age limit for a stem cell transplant. Now, in reality, there probably is. Like, we don't really transplant patients who are over 80 because they have other issues that preclude a transplant. But it is not uncommon that I will send a 75, 76, 77-year-old to get an opinion with the stem cell transplant doctors, and some of those patients will be able to be transplanted. So we've expanded the safety and the pool of patients who can get a stem cell transplant also.
Great. Okay, thanks. Okay, next question. I'm finding very little information about FLT3-TKD versus FLT3-ITD. Does one have a better chance of relapse? And I guess prognosis also is.
Yeah, yep. So just to back up and explain the question, we talked about how there are two flavors of FLT3 mutations, this ITD flavor and the TKD flavor. It's like orange juice versus apple juice. And the ITD has a worse prognosis than the TKD. So the ITD traditionally is always in the bad risk or is always has a worse risk than patients with TKD mutations. The reason for that, I think, is a little bit unclear. So that's how I think about it.
And the treatment for those doesn't necessarily vary, right? It's the same.
Yeah, you
go
always
to targeted treatments.
want to give a targeted treatment, but there's actually a detail which I left out purposely because I thought it was like too complicated, but now I'm going to tell you what it was. So we talked about those two different FLT3 inhibitors, midostaurin and quizartinib. So midostaurin works whether a patient has an ITD or a TKD. Quizartinib only works in patients with an ITD. So, I mean, this is like advanced level stuff, but like if you're a newly diagnosed patient with a FLT3 TKD and your doctor wants to give you intensive chemotherapy with quizartinib, the answer is no, don't let them do that because quizartinib is not effective with the TKD. It's only effective with the ITD, while midostaurin is effective with both.
Mm-hmm. Okay. And there are a couple of other options as well right now. Are they still in trials? Is it?
So there's a clinical trial of this, also a very potent targeted FLT3 inhibitor called gilteritinib in combination with 7 and 3. That's a trial where we're all waiting to see the results, and I'm excited about that. I really like gilteritinib. I think it's a very good drug. And by good drug, what I mean is that I think it leads to remissions, and I think that the side effects are minimal. There was a drug called crenolanib that was being developed, which some of you may have heard about. My understanding is that that drug is not being developed anymore. I'm not sure where things stand. So in terms of FLT3 inhibitors that are kind of prime time, we have two that are approved for newly diagnosed, quizartinib and midostaurin. We have one that's approved in the relapse setting called gilteritinib, and that might get approved for newly diagnosed patients.
Okay, here's a longer question, and you might have touched on this a little bit in the discussion about the maintenance therapy, but I'm going to read the question. What is the best evidence parentheses study we have about determining effective length of time for maintenance therapy after hematopoietic stem cell transplant, such as sorafenib and venetoclax, 1 year, 3 years, indefinitely, question mark. And then this person goes on to say most related literature seems to assume no survival, and so that's not helpful. In the case of survival, when should the drugs be discontinued? And then the person, it's a long question. Please also include some information about potential drug resistance or tolerance. I'm gonna stop there and then
Okay.
we can go to the
Yeah.
rest.
High level question. So just to boil it down, I think the question is like, how long should I be on a maintenance therapy after a stem cell transplant? And when can I safely stop that maintenance therapy? So the answer is no one knows. And that's because all of the studies that have been done with maintenance therapy have given the maintenance, I believe, for 1 year. Maybe it was a little bit longer. We've never had a trial where patients get randomized to receive 1 year of maintenance versus 3 years of maintenance versus 5 years of maintenance. So we just don't know. And I don't think we'll ever have a trial like that. Okay, I just don't think that's realistically going to happen. So then how do you make your decision? So I make my decision in the following way, partially evidence-based and partially because I am a nervous person. Okay, so just to be very, very out there and honest. The evidence-based way is probably after the stem cell transplant to do the maintenance therapy for at least a year, because that's how it was done in the trial, and then send that very, very sensitive test to look for the FLT3 mutation. I think if the sensitive test to look for the FLT3 mutation shows that the FLT3 mutation is gone, I think you can probably stop the FLT3 inhibitor at that point. Having said that, the nervous part of me has the following discussion with the patient. If the patient is tolerating the maintenance therapy without any trouble, right? Meaning they have no side effects from the drug and they feel good and they don't mind taking a pill every day, I will continue the maintenance therapy past a year. I will continue it sometimes up to 3 years. And checking that special test for the FLT3 mutation just to make sure it's not coming back. Again, no evidence for that, but it's because I worry that it might come back. Not the best way to be, but we're all human beings. If a patient, though, is having a lot of trouble with the maintenance therapy, so they're having side effects and maybe it makes them nauseous or they get diarrhea, and like it's really impacting their quality of life. And if the FLT3 mutation is really gone, and I know that I can check for the FLT3 mutation every few months by the special test and see if it's coming back, then I would stop the FLT3 inhibitor. So it's a combination of being confident that the disease is gone while assessing how the treatment is affecting the patient's quality of life. But I don't think there's any situation where I would continue the therapy more than 3 years.
Out of curiosity, you've mentioned this special test a couple of times. Is this a name that patients would have heard at that point?
Yeah, I should be. So it's a test called the in vivo scribe test. It's called in vivo scribe because in vivo scribe is the name of the company that has the patent on the test, and they are the ones that do it. Now, your doctor, basically what happens is that your doctor will order the test, and then the hospital or the pathology lab takes care of sending that test to the company called in vivo scribe. For those of you who live in New York State, like me, up until about 3 weeks ago, we actually had a lot of trouble sending that test because New York State has extremely strict rules about testing, and it wasn't approved by New York State, so it was like a big headache to send it. But it's now approved by New York State, so even in New York, we can send that test. So you're asking your doctor for the in vivo scribe FLT3 MRD test.
Great. Okay, next question. And just as a reminder, if anyone has a question who's on right now and would like to ask a question, there's a little thing at the bottom of the Zoom screen that says Q&A. You can click there and enter your question. Okay, what are the main side effects of new targeted treatments?
That is a very broad question. So, there are a lot of targeted treatments, so it's hard to um, it's hard to give you all the side effects. I'll tell you of the targeted treatments that have been approved to date, I think the side effects fall into maybe three buckets. So one bucket is that most of the treatments, although not all of them, will lower the blood counts to some degree. Not all of them, but some of them will lower the blood counts to some degree. That's sort of a common thread through all of our clinical trials. Some of the treatments can cause a little bit of stomach upset, but nothing nearly as bad as traditional intensive chemotherapy. So maybe just a little bit of stomach upset. Some of the treatments can cause some taste changes. So it's not uncommon for patients to tell me, they'll come in, they'll say, you gave me this targeted treatment and now things taste funny. I mean, that's not unique to cancer drugs or leukemia drugs. Like if anyone has ever if anyone has ever taken Paxlovid for COVID, which I've done, it gives you this kind of metallic taste in your mouth. There's certain antibiotics that do that also. So it's sort of a similar thing. The difference is that you take Paxlovid for 5 days and you take antibiotics for maybe 7 to 10 days. Some of these drugs that we give patients with leukemia are taking a lot longer. So there are things that can be helpful. I have a patient who, I was really struggling to help him out, and then he told me that he started chewing peppermint chewing gum, and it totally fixed the problem. So now that's what I tell all my patients to do. There are little tricks like that that can be helpful that I learn from my patients rather than me telling them what to do. So I think some taste changes, some GI effects, lowering of the blood counts. I think those would probably be the most common things that I see.
And to be clear, I think patients sometimes talk to each other,
Yeah.
right? In support groups or other, ways where they can kind of trade ideas about how to deal with things like that. And I think that's
Absolutely.
really helpful.
Absolutely.
Okay, last question that I have here is, could treatment mean stopping chemo? And I think this is kind of a broad question, but I don't know if you.
Yeah, so I think that question becomes most relevant in older patients where, in younger patients, you're giving chemotherapy and either they're getting a transplant or not getting a transplant, but sort of built into the program is that you stop the chemotherapy at some point. But for older patients who are getting azacitidine and venetoclax, the current standard of care is that, that treatment continues indefinitely until the patient relapses. Now, we have no idea how long you need to be on that treatment. I can tell you that I have some patients who, for a variety of reasons, have stopped that treatment. The most common reason is they are sick of getting treatment every month, which I totally understand. And, it's totally screwing up their quality of life. So I have patients who have stopped and they have not relapsed. They've just done fine. So there is some emerging data that, again, if you look at this MRD testing, that there are some patients who are MRD negative that maybe they're able to stop some of the a treatment like azacitidine and venetoclax. I mean, the problem is that it's not a problem, but those clinical trials about whether you can stop a drug, those clinical trials are typically done by academia because, maybe for obvious reasons, pharmaceutical companies, they have a financial interest that people keep taking drugs. So we actually have a very interesting clinical trial at Sloan Kettering where we're actually giving patients with a different type of mutation called an IDH mutation, the azacitidine and venetoclax, but then we're actually stopping it after a period of time and trying to shift to a lower intensity therapy. I think because I think most of us in the field recognize that being on azacitidine and venetoclax kind of for the rest of your life, especially, if your life is, going to be a decade or something like that, is not a way to live, right? You want to travel and work and play golf and do things that are fun. So we're all working towards an era where we figure out who's curable and whom where we can stop drugs.
So just to clarify, when you say MRD, that's minimum
Correct,
residual
measurable
disease?
residual disease.
Measurable. Okay, and it sounds like overall it's part of kind of a productive conversation with your care team. So when you go to your clinician, you come in with a list of questions that are very specific, right? To say, do I really have to keep taking this? Is there under what circumstances could I not? Are there tests I could be given?
Exactly. You know, it's always a back and forth, right? There's no, maybe this is the last thing I'll say, but there's no cookie cutter way of doing this. Meaning, like, there are going to be some treatments that are going to be the same across the board, but a good doctor will sort of individualize what is happening for that particular patient. And not all patients' priorities are the same, right? You know, patient one might want to go visit their grandchild or, you know, in Florida for 6 months out of the year. And patient two might want to get treated every 4 weeks because that is the most important thing to them. And there's not a wrong or right. So it's really important to find a doctor who's willing to work with you, and willing to, I mean, here's really the last thing I'll say. Not to be afraid of second opinions. I mean, it's important to get second opinions. Any doctor who doesn't want you to get second opinions, I'd be wary of. I tell all my patients to get second opinions. I give them the names of people who I think will disagree with me because we don't all agree with one another, so they can get a holistic view of what's going on. So you want your doctor to be someone who's willing to have you get a second opinion. You want your doctor to be someone who is willing to work with you and sort of, you know, based on what your priorities are and not impose their priorities upon you.
Mhm. Yeah, I think this concept of shared decision making is
Yeah,
really important. Great. Well, that's everything that I have. I don't see anything new, and we're actually at 1:02, so or 2:02 your time. So
okay,
I
great. Well,
think
thank you so much.
yeah, this has been really helpful. Thank you so much, Dr.
Okay,
Stein.
bye-bye.
Bye, everyone.